Hey, this is Andy.
And Randy.
And we're here on AT Corner.
Being an athletic trainer comes with ups and downs, and we're here to showcase it all.
Join us as we share our world in sports medicine.
Welcome back to another episode of AT Corner. Our education episode this week is going back to our position statement series. And in particular, it's going to be the subject, or at least the topic that everyone loved in Gen Med.
All the wrestling athletic trainers love.
Oh yes, we are talking about skin diseases. Yes, and you know what the best part is? We don't have the pictures that make your skin crawl.
Just your ears today.
Yeah, just your ears, which does make it tough trying to describe what they look like. But I feel like I tried to at least put it like, because like when you read like the medical terms on descriptions, you're like, wait, what does that mean again? So I tried to look them up and put it in layman's terms. So hopefully the description, you can at least get an idea. And there are great resources to also look up these like pictures of the conditions and see what they look like. So
I mean, bottom line, all you have to figure out is, does this need a referral or does it not?
100%. Is this normal or is this not normal?
So anyway, this is a CU episode. So if you are wanting to get some CUs, depending on when you listen to this episode, if it's coming out right now, it is free. If you are listening to it within our latest 3 episodes, I believe.
Yes.
It is $1. And if you're listening beyond that, it's going to be regularly priced, but still affordable. Thank you to Mass General Brigham. So go ahead and check the show notes below to go and get your CUs. Okay, Randy, what are we going to
All right, so
today?
The goal of this episode is we're going to discuss the NATA Position Statement on skin diseases. We'll discuss some methods of surface disinfection, and then we'll also discuss some considerations to keep in mind if you do have a breakout of skin diseases. As we dive into understanding how skin diseases happen, we have to understand the basics of infection. And I think at this point, post-COVID, I feel like we're almost all experts, at least on that part. So how the position statement broke it down, right? You need 3 elements to basically create an infection, right? You need a source of the infectious agent. In skin diseases, this is the actual infected person, right? So someone who already has the skin disease. You need an adequate host, which might be you.
Ew.
And then you need a mode of transmission. In particular, we're going to talk about 2 that are kind of predominant for skin diseases, and that's either a direct transmission, which is basically skin-to-skin contact, or an indirect, which is contact with an object or a surface that was touched by the infected person. So this could be like your treatment tables, wrestling mats. Ugh.
Yeah, friendly reminder to clean your treatment tables.
Yes, it doesn't seem like a big deal, but it definitely can be, especially with just sweaty, gross athletes hopping on and off.
Right.
So, we have to start with everyone's fun ones. We're going with the fungal. Get it? Fun ones? Fungal? Fungi? Bringing all the jokes here today. So, fungal infections are caused by what's called dermatophytes. These are fungal organisms that live in the soil, animals, and on humans. All right. And essentially where they live is they survive on the dead keratin cells in the stratum corneum, which if we're all diving back into our histology class, that is essentially that outermost layer of epidermis, which lucky enough for the fungi have a ton of dead keratin. So
we love that.
Yes, they have a lot to feast on. So basically just dead keratin cells everywhere. So these fungal infections are essentially the tinnias.
Mm-hmm.
So you have tinea capitis, which occurs on the scalp, tinea corporis, which is everyone's classic ringworm.
Ew.
Yep, this can occur on the head, neck, torso, upper extremity, and lower extremity. But what they made a note, this is actually kind of rare.
Actually, I didn't know that, but I feel like whenever I've seen it, it's on the upper arm.
So it's funny because, again, I didn't know like it was rare for the lower extremity, but
or I've seen it on the torso.
Okay,
like,
yeah,
abdomen.
But it's funny because, and we'll talk about kind of like that breakout aspect, but like we had at one of the institutions my women's soccer team had a breakout of ringworm, and it was all on the lower extremity.
Oh, interesting.
So it's so funny that they said it's rare.
Oh, that is funny. I was thinking maybe because do you have less dead keratin cells on the lower extremity?
That's a good question.
Like maybe you shed more in...
Well, I could see that because like upper extremity, right? It's more active. You're touching more things. So I guess I could kind of see that.
Yeah, but you're walking. You use your legs to walk.
Yeah, but they're closed. Like a lot of times, like pants and stuff like that, or like your shoes. Shorts. Yeah, I don't know. That's weird.
Yeah.
That's a good, yeah. Maybe
if
it just
anyone
doesn't...
has to answer that question, please
it likes to be closer to the sun.
Yeah.
Continuing on with the tinnias, you have tinea cruris, which is the pubic region, and then tinea pedi, which is athlete's foot. Right now, I have an athlete that has major tinea pedi.
No.
Like I almost see spores. I'm like, bro,
no.
you gotta get a cream.
Yeah.
Before it gets too far and you need like actual oral medication. You need, yeah. All right, so breaking it down, kind of what they're going to look like. Tinea capitis presents with kind of gray scaly patches with mild hair loss. The position statement had a pretty good picture of kind of what it looks like. Like it basically kind of looks like a gray ringworm, but in your hair. And there is an area where there is it's a little thinning in the hair. So you're going to see some hair loss in that spot, which can kind of give you an indicator.
Also, the position statement does have some pictures, but also if you'd like to see pictures on dark skin, there's a website called blackandbrownskin.co.uk/mindthegap, where it's also going to be in the show notes. And this is a really good resource for like skin conditions and not just on your typical white skin. They have various submissions that people have submitted, and you can also submit your own. After you get a doctor's diagnosis, you can submit for that. So if you have an athlete with a various condition, like it's always a good idea to look at what they don't always present exactly the same. So it's good to see what it looks like.
Exactly, 100%. And the position statement did offer some like good like textbook resources, but again, like how skin conditions have been studied, right? It predominantly has been pictured on lighter complexions. So it is nice to just get an idea of what that looks like on everybody.
Mm-hmm.
So going into tinea corporis, these are very well-defined round, ready scaly plaque with raised borders. So it's going to be like kind of a circle, right? It's going to have a red it's going to be very red. It's going to be a little scaly, and those borders should be raised. Now, in athletes, it's actually termed tinea corporis gladiatorium. It's just basically saying, hey, you're athletic and you have ringworm. But what I thought was interesting, in athletes, it may present as kind of irregular. So it may not be like super round, which again, that was what happened in my outbreak with women's soccer athletes.
Oh,
it did not a lot of the lesions were really round. That's what made it really tough to kind of identify that, oh, this is ringworm.
Oh, interesting.
Yeah, I thought it was very interesting. See, if I would have just remembered the position statement.
Also, it has a scaly plaque with raised borders is psoriasis.
Yes, you're right. Yeah,
which is a very non-contagious condition.
Yeah.
So
what was interesting, though, is the position statement brought up how some of these skin conditions, and more kind of going towards like your viral and bacterial infections, actually get paired up with like eczeema and stuff. So already kind of pre-existing conditions, because there's damage to the skin, and it allows those agents, like those infectious agents, to get into the skin and then multiply.
Right.
All right. So there's their entry into the body.
Honestly, that's how I have determined some skin things, if it's eczema or not, because I am very familiar with how eczema looks on my skin. So
which, by the way, has helped me out as well.
Right. And so like I feel like this is one of those things that like once you've seen something, like experience really is helpful in this.
100%. So just keep that in mind with like ringworm, is like everyone thinks of it, the ring, right? Everyone thinks of the circle. Oh, it's well defined, it's round. But in athletes, it may not present that way. So if it kind of looks a little weird and it has those raised borders, you know what? This might be ringworm. Let's get it looked at. Essentially, so when we're looking at treatments for these tinnias, if they're really localized lesions, a topical treatment's fine, like an antifungal cream, that'll work out pretty well. But if they spread and it's very systemic, they may need an oral antifungal to combat this infection.
Oof.
Oh yeah, that's not fun when you have to do the the prescription meds. In the case of tinea capitis, so with it actually on the scalp, they're pretty much going to jump to a systemic treatment and antifungal shampoo. It's pretty difficult to treat, so they do kind of the oral medication and a antifungal shampoo. And no one wants to be that kid that has to do with the antifungal shampoo. It's like when you're a kid and you had lice. You had to do the shampoo. The lice shampoo.
No, the lice comb.
Oh, that one's worse. Ooh, that's worse.
Okay, so what's the return to play for this?
So
or can they play with this?
In the short term, not necessarily. So tinea capitis, they're going to need to have 2 weeks of systemic antifungal treatment.
Try to tell Coach that.
I was going to say, this is definitely one of those fun things to explain to Coach. They're fine. Well, no, they're really not. They have fungus growing on them.
Yeah.
So yeah, tinea capitis that is kind of a bummer. They're missing 2 weeks to be able to actually get the systemic antifungal treatment.
Tinea capitis is the one on their head.
That's on the scalp, yep.
Okay.
Tinea corporis, so again, ringworm. They need to have a topical treatment for at least 72 hours, and the wounds may be covered for them to be able to participate.
So for the first 3 days, they can't participate?
They cannot. They need to have topical treatments.
Even with their wounds covered?
Yep.
So you see ringworm, they're out.
Yeah, for 3 days. So that's why it's important, like, hey, let's start treatment quickly so we can minimize how much time you're away.
Also, don't touch them.
Yeah. Yeah, man. I'm never going to forget that outbreak. I was just like, everything was cleaned.
Yeah, wash everything.
Don't share towels, guys.
Ew.
It was gross. All right, so those are your fun guys. All right, now we're moving into our viruses, which, again, we got pretty comfortable with viruses in 2020.
Yeah.
So for skin infections, the position statement really only talked about 2 viral infections, right? Their primary causes are either going to be a herpes simplex or a molluscum contagiosum, which, man, I forgot about that bad boy.
So it was mouthful.
Nice. Yeah, it was nice to dive back. Like, man, I remember hearing about that.
I remember hearing about that. I hope I never have to see it.
So for herpes simplex, the incubation period could be 3 to 10 days. So if you're exposed, right, it's going to take 3 to more than a week before you might, start to feel those symptoms. Mm-hmm. Symptoms can vary from a mild viral illness, right, like some common cold symptoms, to more severe symptoms like fever, general malaise, joint muscle pain, conjunctivitis. I thought that was just kind of interesting. Like, that was really pointed out. I think all right.
Viruses in general have conjunctivitis.
Really?
Yeah.
Interesting.
I mean, maybe that's an overgeneralization, but I'm pretty sure, like, I've heard of a couple viruses that you see conjunctivitis with, so I can't make the full statement that
all viruses,
all of them, but I've seen conjunctivitis with more than one virus. So herpes would make sense.
Yeah, for sure. And then you can also see enlarged spleen and liver. So, see, that could definitely be tricky if you have the enlarged spleen and malaise and fever. You're like, oh, mono.
Oh, true.
Right? That kind of gives you that, like, mono vibe. So that's why it's really important. Like, hey, let's rule some stuff out.
Let's not get those mono vibes.
Yeah, no. So then after these symptoms, you'll kind of start to see the lesions start to appear. This could be on the face, right? Everyone normally thinks of the cold sore, right, on the lip. It could be the neck, trunk, or the arms. And what these kind of lesions look like are they're basically clustered vesicles, which what these are basically just small little fluid-filled sacs, and they're going to have a red base. They can rupture over a period of 7 to 10 days. When they rupture, like, that's where the virus is at. Don't touch those, right? So that's why them rupturing is kind of a big deal.
So they're almost like extremely filled pimples.
Yes, yeah, I would say, yeah.
But there's like a cluster of them.
Yeah, they're like
it's not just one.
Yeah.
They're like in clusters.
Yeah. Treatment for this is going to be just essentially antiviral medication. The nice thing with this medication is it shortens the duration of the infection. So how long their infection's like present, it can kind of cut that time down. And it can also help reduce the transmission of the virus. So it does help protect others as well. It was important to note, though, after like they start to crust and stuff, that medication really doesn't really have that much more of an effect. So the earlier they can do the medication, the better. So once you do your treatment, right, now we got to start talking about the most important question to coaches or to the athlete is when can I play?
Yep.
When can I go back out there?
Yep.
And essentially we're looking for free of systemic symptoms, right? You can't be going out there with your spleen, 5 times the size of normal, or can't go out there if you're feeling laced.
Right. Well, they'll try.
They'll try. They want to. They think their 20% is better than someone else's 80. They should not have any new blisters, which essentially that's kind of what they look like mini little blisters. Like I said, like kind of a fluid-filled pimple. Yeah.
Filled blisters.
No new blisters for 72 hours. The lesions must have been completely crusted over. So they've ruptured and they've kind of crusted. That's perfect. That it should be very like a sealed kind of area. And then they need to have at least 120 hours of antiviral treatment, which I believe that's 5 days.
Yeah, that's 5 days.
Look at that mental math. And then if they are having active lesions, they cannot be covered. So if they are in a flare-up and those lesions are active, they look like those fluid-filled sacs, they cannot be covered to play.
So you have to wait.
You have to wait.
Until no new blisters are formed.
Yep, and the current ones have crusted over and you're taking 5 days of your antiviral. So, after herpes, we have the mouthful. The mollusc. Molluscum contagiosum. That's
sounds
quite the
contagious.
Name. You know what? That is something that you hear and you're like, ooh, that sounds gross. That sounds like I can catch that.
Mm-hmm.
It is a part of the pox family, so it's within like that whole it looks like a pox kind of thing. How it's described is it's an umbilicated, flesh-colored to light pink papule. So what umbilicated means is the center is going to be depressed, kind of like a belly button.
Like a belly button?
Yeah, kind of like a belly button. So it's going to be like a mini belly button within a bubble.
This almost looks like herpes, but yeah, like with a little depression.
Yes. And also, how they also define it is it can either be solitary, so it could just be on its own, or it can be clustered, but it's not going to have more than 20. So there's going to be a limited number of actual little bubbles, unlike kind of herpes where it could be a lot, and it could probably be more than 20. So that's kind of like if there's not really that many, this is what you're going to kind of suspect. And obviously, if you see that little belly button in the middle of the bubble, that's kind of a good, yep, that's contagiosum.
Yeah, these pictures are not very nice looking.
No, not at all.
Are they itchy?
No, they didn't describe it as itchy.
That's probably good because it looks like they're going to pop.
Yeah. So the treatment for this is basically scraping off the lesion. So They basically just scrape that bad boy right off. And that's kind of the return to play criteria is, hey, those lesions have to be cut off and then you cover that area.
Doesn't that make you want to be a dermatologist?
This whole position statement said, yes, I want to do this for a living. I want to see these all the time.
Uh-huh.
Actually, I wonder how often people come in with skin diseases.
When I did my physician rotation, we saw a whole family who had staph.
That is such a bummer.
And they had a newborn baby.
Aww.
It was like a family of 5 and they had a newborn.
Poor baby. Who had staph?
The baby didn't have staph yet.
Oh, poor baby. Yeah. I mean, good thing it didn't, but it's not looking good. That baby might get a staph infection.
I know.
Oh, that's such a bummer.
They had 3 kids. It was a family of 5. It was 3 kids under 5.
Uh-huh.
And then the mom and the dad. I think the mom and the baby did not have, were not infected yet.
Okay. Nice. So those are our viruses. Again, just like how we feel about the pandemic, we want to move on from the viruses, and we're going into bacterial infections.
I approve of that transition.
Yes, we're going to go to bacterial now. First one that the position statement went over was impetigo, which actually, when I was a student, one of our rotations, the football team had a breakout of impetigo.
Man, I have, knock on wood, not had to deal with a big breakout. I don't like hearing these stories.
Yeah, it's gross.
So far, I've only had like one time.
One case?
One time actually, you know what? Oh, okay. We had a scare because one kid years ago had tons of bites on his legs or lesions. And then he was freaking out. He came to us and was like, we have like, I have these things all over my legs. This guy has things all over his legs. This guy has things all over his legs. And we were all in the jacuzzi together.
Uh-oh.
Last night.
That's
and I
a
was
cesspool.
like, oh, shoot. So then we watched them because they didn't, I don't remember what they looked like. I mean, they kind of just looked like mosquito bites.
Yeah.
But we kind of like watched them and then it didn't end up sending them. And they turned out to just be mosquito bites.
Nice.
But the kid was like freaking out and we're like, oh man. And then he was like, oh wait, this person too. And
uh-oh.
Yeah.
Contagion.
Yeah.
Patient 0.
That was like the one time it actually was mosquito bites. You know how people are like, oh no, they're just spider bites.
Oh, which we'll talk about the spider bite. So for impetigo, there are 2 forms. There is a bullous form, which this creates superficial blisters, but the rim around the blister is going to be very scaly, which when you kind of look at like impetigo in general, there's a lot of like scaly, crusty crap.
It also looks like psoriasis.
Yes. And then there's the non-bullous form. So this is the most common. This is what most people probably think of when they think of impetigo. They're going to basically be just little thin vesicles that rupture, and it exposes the raw skin underneath. And this is going to be surrounded or covered by a yellowish or honey-colored crusting. So that's kind of like the big thing when you think of impetigo, is that crusty kind of like area of the skin.
Yeah, I feel like when you see crusty, usually it doesn't mean
that's
good
not
things.
good.
Yeah, especially if there's like more than just one thing.
Yeah, for sure.
Oh yeah, that's nice and crusty.
Yeah. But you see, look at the red base.
Mm-hmm.
Okay. Treatment for impetigo is going to be really topical antibiotics. This could actually be just as effective or even more effective than oral antibiotics, because if you account for side effects, right? Oral antibiotics have a lot of gut issues. So if you going with a topical antibiotic can be just as effective. When we talk about bacterial infections, the return to play is basically going to be the same for all of them. They need 72 hours of antibiotic treatment. No further drainage of the lesion, so there's no actual like fluid coming out anymore. Like, it's pretty much looking like we're healing. They should not have any new lesions for 2 days, and then active lesions cannot be covered to play. So if they are active, they cannot play.
I feel like this is kind of standard. Like,
yes,
once if it's an active skin condition, you can't cover it.
Yeah.
If they're on treatment for it after 3 days, for the most part, honestly, if they're going to a doctor, they should be getting a clearance anyway, or guidance. But kind of just for our own guidance, for if it's been treated for at least 3 days, most conditions fall under that.
Yeah, for sure.
The only one was 2 weeks for the scalp.
The tinea capitis. So after impetigo, the position statement went into your folliculitis, furuncles, and carbuncles. Those are very interesting words. Essentially, these are caused by some form of staph. So folliculitis, right? The term itself is just basically a follicle that's swollen. But when you're talking about the actual infection that can get inside from like any damage to the hair follicle, this would be the staph infection part.
So I have seen a lot of folliculitis from like under ankle tapes.
You know what's funny? Bringing that up, that's kind of what they talked about. Like shaving tape can kind of cause this irritation that can open up that door for staph to get in and then create a bigger infection.
Right. So I had a kid who we were like, oh, you look like you have folliculitis. You should go get treatment for that. And then he came back and we're like, did you go to the doctor yet? And he was like, no, I talked to my mom and she said that it wasn't contagious. So we decided not to go to the doctor because we didn't need to. And I was like, no, we didn't say go to the doctor because they were going to take you out. I was saying go to the doctor so you can actually get that treated so you're not sitting with folliculitis on your leg.
Yeah.
And he was like, oh. I was like, oh my goodness, we're not trying to take you out, kid.
Yeah. So
We're trying to make your legs feel better.
yeah, for sure. So folliculitis, right? They're basically going to have little pustules in those hair follicles, so the hair growing areas, right? Hence folliculitis, hair follicle.
It also kind of looks like pimples.
Yeah, it does. It does kind of look very similar to like pimples. Like little
I
pimples.
should have taken a picture.
Yeah, that would have been cool. Next, you have your furuncles. This is essentially when people talk about boils. That's what these are. They're basically a reddened nodule of swelling that can eventually develop into an abscess, so a pocket of pus. To make you feel even better about that, they can rupture spontaneously. Just like that.
Sound effect of the day.
Yeah,
Disgusting.
especially when you're like eating breakfast or having your morning coffee. Just what you want to hear. A nice furuncle going. And then we progress to multiple furuncles joining forces to form a carbuncle.
There you go.
Yeah, just like that. So a carbuncle is multiple furuncles basically combining. So it turns into one ginormous abscess. So essentially for the treatment, because of the appearance of these kind of staph infections, athletes should be referred for antibiotic treatment and also to rule out conditions like MRSA, right? Because they do present very similar. And obviously MRSA is kind of a big deal because it is resistant to a lot of different antibiotics that we have.
Yeah, there's a big difference between MRSA, which is very contagious, and your folliculitis furuncle carbuncle, which could be pretty innocent.
Yes. Furuncles, really, you're going to use a warm compress to just kind of promote that drainage, kind of get just like that pus and grossness out. For the carbuncle, because of just we have multiple furuncles happening, it requires basically incision and then drainage. So this for sure needs to be referred.
Yeah, the ones I'm looking at, they're giant.
Yeah. And
although I feel like if you're going to post it on the internet, it's probably going to be giant.
it's got to be pretty cool.
Yeah.
So basically they create the incision, drain it, and then start antibiotic treatment.
That is one thing that I feel like we learn to see like the extreme cases because they're the easiest to identify.
And it hits all the textbook, like this is what it looks like.
Right. But I feel like all the like in between, we don't really get a good like start of. What is the start of a furuncle look like? Or what is the start of MRSA?
And also too, like another thing that we have to remember is like there's literally a medical specialty devoted to this.
Mm-hmm.
And like we're getting just like not even like the skin surface of what this is. Like I feel like we're getting even less than that. Yeah, pun intended. I feel like we're getting even less than kind of that. So like,
which is why you have to determine when you have to punt to dermatology.
Exactly. Again, the return to play, as with bacterial infections, at least 72 hours of antibiotic treatment, no further drainage from lesions, no new lesions in 48 hours, and no, you cannot cover this to play.
You cannot cover what to play?
Furuncles, carbuncles, and if it is truly like a staph infected folliculitis.
Even if
it's determined that it's a staph infection, like a staph folliculitis.
So if folliculitis, furuncles, and carbuncles have been ruled that they're fine, they can play. Yes. They can be covered in place.
Because then it's not an infection. It's just, it could be like a pimple kind of deal.
Right.
And then we can't talk about bacterial infections without talking about the big one. MRSA. It just sent chills down my spine.
You're calling all wrestlers.
So, right, MRSA is basically a methicillin resistant form of staph, right? So it's resistant to a lot of different antibiotics that we currently use for bacterial infections. Initially, it can present like folliculitis or a furuncle or even a carbuncle, right? So that's why it's important when we talk about like those other ones to go and get that ruled out.
I feel like all the pictures of MRSA look so different. Like, I feel like there's not one that's like, oh, that's what MRSA looks like.
You know, that's the tough thing with MRSA, is it just presents like so many different things.
And that's why it's so prevalent.
Yes. And this is what we were talking about when we were talking about mosquito bites or the bug bite.
Mm-hmm.
This is the classic spider bite look, right? And one of our professors had a great way of bringing this up in class. He was like, people would tell him like, oh, it's just a spider bite. Did you see the spider?
Oh, yeah.
Oh, no. Well, then how do you know?
Right.
Right. So
just trying to make myself feel better.
Yeah. So anytime you get that, like, oh, I think it's just a bite kind of thing, but it's just kind of not, it just kind of looks a little weird, let's rule out MRSA.
Mm-hmm.
Basically it kind of starts out looking like maybe like a folliculitis or a carbuncle kind of thing, but then it can advance to a large pustule or even an abscess with redness around it. And here's kind of like what might help differentiate it, but I feel like this is kind of advanced. It'll have like necrotic tissue in there somewhere. So in the position statement, they had a pretty good picture where you can kind of see like it kind of looks like a carbuncle kind of deal, but there was like a black spot in it. That's the necrotic tissue. So I feel like that's definitely severe if tissue's starting to die.
You also have to be careful about when you're looking for that, because if you're looking at a wart, they can have black dots too.
Yes.
And warts are contagious too.
Yes.
Did the position statement talk about warts?
No, because it wasn't going quite into those kind of skin infections, right? So they did not talk about warts. So a treatment for MRSA is going to be a little bit more like time sensitive and intense. They need to be immediately isolated from the team, right? Because we're not trying to give everybody MRSA.
Yeah, no thanks.
And then the treatment's actually going to depend on kind of the local data. That's how the position statement said. So kind of understanding the kind of strain it is, what it's been resistant to, what has helped is going to determine what antibiotic they're going to use.
Right.
How we talked about it in class is a lot of times they just like, let's throw some antibiotics, see what happens, see which one works, which one doesn't.
Great.
Because it is definitely very resistant to a lot of forms.
Mm-hmm.
And again, the return to play is going to be similar to your other bacterial infections. 72 hours of antibiotic treatment, no further drainage, no new lesions, and definitely not covering to play. So those kids that will ask you, can we just cover it? No. Nope. Usually, I already know. I know what team of mine would ask me that. And I'd give them that look and be like, no. What are you doing?
No.
Yeah.
So is that like the majority of the skin condition?
That was it, yeah.
Okay, sweet. So now we get to talk about what we can do to mitigate them?
Yes. So a big emphasis was put on just good hygiene. Just be cleaner. I thought this was interesting. Again, like I read this position statement as a student, but I don't know. Now with like certified eyes, this position statement just hits different. They actually talked about washing hands, and the CDC, when this came out, I think this position statement was from 2010 or something. Mm-hmm. The CDC at that time, or around that time, put out a 56-page report on washing hands.
Like what? About what?
Just its benefits and like how to do it properly and all this stuff. They had a task force.
Well, you have to slough off the dead keratin cells so you don't get a tinea viral infection.
Yeah, it's true.
I mean, not viral. Fungus.
Fungal,
yeah. A tinea fungus infection.
But they put a task force for washing hands.
Someone had to do it.
Yeah, someone had to do it. What was interesting though, how just times have changed. The position statement said to wash hands at least 15 seconds. But I feel like now people talk about 20 seconds as the barometer.
Happy birthday twice.
Yeah, happy birthday twice.
I had after when I was a student, when we had our like hand washing, you talk about hand washing, we had like a little break and I went to the bathroom and then my professor was also going to the bathroom and then we got up at the same time and washed our hands. And I was washing my hands right next to the professor that was like telling me how to wash hands, and I was like, this is gonna be the best time I ever wash my hands ever. I was like, I cannot turn off the water before she does.
And they just brought up like things that I think we do really well as clinicians, right? After you touch an athlete, right, you should wash your hands. After wearing gloves, right, you should wash your hands. They brought up a good difference, like if your hands are soiled, right, so if they're like dirty or like stuff's actually on them, you should definitely wash your hands first. And then you can do like the washing hands will be fine, but then you can add like a alcohol-based sanitizer. But if your hands are fairly clean and not soiled, you can do like a sanitizer. You don't have to necessarily also wash your hands, but I like washing hands. I don't know.
Right.
I feel like soap and water is pretty good.
You just have to, if you're prone to drier skin.
Yeah, good point.
You just have to hand lotion. Have a good hand lotion.
For sure. Good point. I'm pretty lucky. I don't have a lot of dryness, so
that's nice.
That doesn't hit me as hard. Another good point is also just educating our athletes, right? A lot of them they really just do not care. They just, oh yeah, use this. Oh, hey, I have this. You can use it, right? Remind them like, hey, maybe we shouldn't share all of our equipment or personal items, right?
Right.
Like
they also talk about like, don't share razors.
Yeah. I don't know why that's a thing. I feel like that's gross.
Yeah. Oof.
Like I would not want to use someone else's razor.
Don't share your toothbrush.
Yeah. Seriously. Right. And like, I don't know, man. I almost want to be like, have you seen some of your teammates, man? You really want to share with these guys? Like,
and that's how team outbreaks happen.
Exactly. It is not a team bonding experience.
No. Well, it might be.
Yeah, it could be. Another thing that they did bring up is, as with most things in athletic training, we need to make sure we have the appropriate policies and procedures. One thing that was kind of cool that I guess I never really considered, because I've really never been at a place that had wrestling, but they had like the idea of, hey, determining a cleaning schedule. When our facility is getting cleaned, how often, what chemicals being used, and all this, right? So it was recommended that, hey, this should have a schedule for athletic services, locker rooms. You should be utilizing your equipment staff and custodial staff to make sure that, hey, we are sticking to that schedule, like the chemicals that they're using and stuff like that. One thing that I know I've started using ever since COVID, thanks COVID, is determining how often a surface is getting cleaned and what agent you're using to actually clean it. So making sure that agent is registered with the EPA. So there is actually a good resource. I think it was in the position statement, like the link for it, that has like a little database. You could put in the chemical in there, and it gives you a nice breakdown of what is it good for, how long should it sit, how it should be diluted to actually properly work.
So I know that this was a big thing during COVID, but I think now in the next, like, it's been a couple of years, so like the next generation too of athletic trainers is really pay attention to what you use to clean and how long it does have to sit, because some of them have to sit like 10 seconds before you wipe them, or some of them you're not supposed to wipe them, they're just supposed to evaporate, or some of them are supposed to sit like 10 minutes. So if it's supposed to sit 10 minutes, at least get that, maybe like if you can't have that obviously in between each person, like at least once or twice a day, at the beginning of the day, at the end of the day, or like maybe in the like 3 times like in the middle of the day, at least get a good like soak in where you actually clean the surface. And then how many times are we actually cleaning our rehab equipment? When
100%.
was the last time you cleaned your dumbbells?
100%.
When was the last time you cleaned the handles on the TheraBand?
100%.
Tower.
Yeah, 100%. That's actually what I was going to talk about, is that sit time is very important, because there are certain products, and there's kind of like a major one that I feel like a lot of people use, that I feel like they put it on and wipe it really fast. And it's just like, technically that's got to sit for a while. Right. And, people just don't necessarily think, they just think like, oh, I'm wiping, I'm disinfecting. So to make sure that it is truly effective, right, we need it to sit for its appropriate time. And that's why the EPA like source is really cool, because you can find disinfectants that are 30 seconds. So maybe if you're trying to like, hey, like, I think, I'm trying to improve the way we disinfect our facility. Hey, maybe this one that sits for a long time isn't going to be right for your setting. So we can find other ones that can help. Yes, during COVID, I did dive into that when I was making our disinfection policy. It was really cool. And it did help. Policy. And it did help, again, inform the choices of what we were purchasing. It was pretty cool. I enjoyed it. I'm nerdy like that. Another thing that they brought up is making sure that your sports medicine team is ready to handle skin conditions. And one thing that they brought up was a team dermatologist.
Interesting.
I know. I feel like, again, I read this as a student, but again, with certified eyes, I think it just meant a little bit different now. But I never thought of having a team dermatologist. And I think one reason why that's really not thought about is because most of our like insurances, I don't think really cover that. So it's not like you can necessarily just easily refer them to, oh, I'm just going to refer them to my team
What do
dermatologist.
you mean our insurances?
Like the school insurances.
They don't cover a dermatologist? They should.
Athletic injury. That's not athletic injury.
Oh, you're right.
Yeah.
But I mean, I guess you'd have to see because some of them do cover illness.
Oh, do they? I've never had...
Like if you have like a cardiac concern that happens during sometimes.
Well, I think that could be slightly different. Okay. I think that is definitely a gray area for sure.
Right.
Because I know if I sent someone with chest pain, that would be covered.
Right.
But like if someone had the flu,
right,
that wouldn't be covered.
Right.
So yeah, that's right. That's interesting.
Check your insurances.
Yeah, but for the most part, I feel like because it's not necessarily an athletic injury, I don't think they would because they don't cover mental health.
Well, your school should have mental health.
Yeah, but like if you need to go outside, like if you have limited resources, right, you'd be a little limited. So yeah, I thought that was interesting that having a team dermatologist would be pretty clutch.
I mean, I feel like if you see skin conditions enough.
Yeah.
Or like, at least have someone on call. Have someone on call.
Have someone that you can at least utilize.
Like your team dentist. Like you're not going to use them that often, hopefully, but
have
them on call.
Yeah, for sure. So yeah, I thought that was really cool. Now I want to find a team dermatologist.
Of course you do.
Hey, the position statement said.
You're right.
And there you go.
What's the action item?
If it looks weird on skin, refer.
My action item is if it's gone to the doctor and there's no new active blistering or redness or active whatever skin things do. That's very technical.
Yeah.
Most of the time they're going to be back 3 days that you could start to cover.
If it looks less weird. There you go.
If it's not active.
Yeah. It's not actively odd.
It's not actively bizarre.
Yeah. But yeah, there you go. That's how you're going to start your day. Talking about some skin conditions. And now everyone who walks in, you're going to think, oh, that looks weird.
Yeah, you're not going to want to touch anyone's
skin. Yeah, you're not
going
to.
I did have a kid walk in with a wart that was opened. And I've actually had a couple warts lately, which is why I brought it up.
I have not had a lot of warts lately, but I have had a lot of plantar warts in the past.
They were both on hands.
Interesting.
One is right in the middle of the palm.
Oh, that sucks.
I know. And then the other one is we've just been donut patting it, and covering it, and then the other one, and I told him to go get it. What do they use? The liquid nitrogen.
Yeah.
And then,
or they can cut it out.
Oh yeah. I think the second one has to go get liquid or get it cut out because they tried liquid nitrogen already. I mean, it was pretty giant. Like it was giant enough that it opened.
Dang.
I've never seen a wart open before.
Oh, like this, just almost basically like a
on
cut.
His thumb.
And it just kind of like split.
Well, it's like maybe a centimeter tall. Like it's huge.
Dang, that's
and then
huge.
It's split open. I know, it's giant.
That's gotta hurt. Split open?
Yeah, it was all bloody.
Ugh. I have calluses that split open and it hurts. My tape calluses.
Yeah.
I used to have really bad warts on my hands when I was younger. They were ginormous.
Well, aren't they? They're contagious, right?
I believe so. I think so. It is a virus.
Right.
But yeah, there was one time I had to freeze them all at once. Mm-hmm. Dude, my hand was crushed. I could not use that hand.
Aw.
All right.
Nice.
And on that note.
So if you are interested in CEUs, go ahead and scroll down the show notes. We have, I believe the link says, get your CEUs and your course evaluation here.
And then
there'll
be a link.
Yes. Again, thank you to our partner, Mass General Brigham. If you are interested in every other episode, we do education or stories. So this one was an education episode. Next week, we're going back to our stories. I don't remember what it is off the top of my head, but it will be on our Instagram. Usually around Tuesday or Wednesday, we'll post questions to prompt you guys of what stories we're trying to get. And then we also have a MedBridge offer for $150 off of MedBridge if you use code ATCorner. And it is a reporting year.
Yes.
The best part about getting it now is if you purchase a subscription, it's a year long. So you can use some of the CEUs for this year, finish out this year, and then your subscription still goes into the next reporting period, so you can use them for next year too.
Yeah, absolutely. And then they also have like other plans that include their like home exercise programming, which is really cool and intuitive, and it's pretty user friendly. So there's a lot of options when you talk about MedBridge.
Yes, athletic trainer friendly.
Yes, it is very AT friendly for sure.
Yeah. Do you have anything else?
Nope, that's perfect. Thank you for helping us showcase athletic training behind the tape. Bye. Skin.